Hi, I'm Jade Fizette, and today, along with Stephanie Anderson and Josie Blake, we are going to be talking about two treatment methods for aphasia: the Helm Elicited Language Program for Syntax Stimulation, also known as HELPS, and the Response Elaboration Training, also known as RET. We're going to give you guys a brief overview of aphasia. So, aphasia is often caused by a stroke or other disease and is a communication disorder that occurs due to damage in the language centers of the brain, so typically in the left hemisphere. The deficiencies present vary, but can include difficulties in speaking, listening, reading, and/or writing. Due to the variability in the difficulties presented in a person with aphasia, treatment methods can also vary. The two treatment approaches that we are going to be talking about are the Helm Elicited Language Program for Syntax Stimulation and the Response Elaboration Training Method.
The Helm Elicited Language Program for Syntax Stimulation, also known as HELPS, was originally developed for treatment of agrammatism. More recently, clinical experience, however, has shown that HELPS easily lends itself to the treatment of paragrammatism. Agrammatism can be defined as a loss of syntactical knowledge or reduced efficiency in gaining access to or expressing that knowledge. The purpose of the HELPS is to improve grammatical skills of adults with acquired aphasia. HELPS is a hierarchical, structured approach to treatment of grammatical disorders associated with acquired aphasia. 11 sentence types are presented, each at 2 levels of difficulty. Level A requires the client to produce a delayed repetition of the target sentence, which has been presented by the clinician in a story format. For example, the clinician says, "My friend is oversleeping." So I tell him, "Wake up." What do I tell him? And the client says, "Wake up." Level B requires the client to complete the story with the target sentence without benefit of repetition. For example, the clinician says, "My friend is oversleeping," so I tell him what? And the client says, "Wake up." Each session is scored. When score criterion has been reached for sentence type 1, at level A, the client is introduced to level B for sentence type 1. When score criterion has been reached for sentence type 1, level B, the client is introduced to sentence type 2 at level A, and so on until the client can produce all 11 types at both levels of difficulty. On the next slide, we will talk more about the hierarchy of the 11 HELPS sentence types. The HELPS is appropriate for the use with aphasic individuals with grammatical disorders and moderately to well-preserved auditory comprehension. As well, it is inappropriate for globally aphasic clients with little or no speech output, or clients with severely impaired auditory comprehension.
The following is the hierarchy of the HELPS sentence types. The sentence types include imperative intransitive, such as wake up, imperative transitive, lock the door, WH interrogative, what are you eating, declarative transitive, he paints houses, declarative intransitive, he sings, comparative, he is taller, passive, the car was towed, yes, no questions, did you buy the paper, direct indirect object, he gives his son a toy, embedded sentences, he wanted him to be rich, and future, he will travel. Each verbally offered exemplar of each sentence is accompanied by an appropriate action picture that is presented coincidentally with the story.
Each of the story completion tasks are accompanied by a figure line drawn picture, and the clinician has the opportunity to train the patient with 2 broad forms. As explained before, in level A, the patient repeats the target phrase which is embedded in the story for repetition purposes. At this level, the clinician uses delayed imitation in order to increase generalization. In level B, the target phrase is not included, and the goal is for the client to complete the story with a personal response. The patient's short-term goals for treatment should be set at 90% accuracy before moving up in the hierarchy of treatment. Watch our example of this.
So this is the kit that the Helm Elicited Language Program for Syntax Stimulation comes in. And it comes with a manual and then these booklets over here.
We're going to show you an example using booklet number 1. The boy's grandparents are leaving, so I tell the boy, wave. What do I tell him?
Wave.
My friend feels dizzy, so I tell him, lie down. What do I tell him?
Lie down.
Good job. And potentially whenever she reaches 90%, we would, and it could be in a different session, we would go back and use the same stimulus pictures and do level B. The boy's grandparents are leaving, so I tell him what?
Wave.
My friend feels dizzy, so I tell him what?
Lie down.
Awesome. The HELPS approach was first developed by Nancy Helm Esterbrook. Early studies of the HELPS approach found little evidence of generalization amongst participants. However, a more recent study conducted by Fink and colleagues during 1995 found that the approach improved sentence production. The study examined 7 individuals with non-fluent aphasia. 4 of these individuals were randomly selected to receive the syntax stimulation protocol, which is another name for the HELPS approach. While the other 3 individuals served as controls, participants were trained at level A and then at level B 3 times a week. Criterion for moving from level A to level B was 8 out of 10 correct over 2 sessions. To promote generalization, each participant viewed a 10-minute movie at the end of each session and was asked to retell the story. Data showed an improvement in 3 out of the 4 participants and found that the HELPS approach helped to generalize untrained exemplars of trained structures.
The second approach to treatment we are going to talk about is called the Response to Elaboration Training, or RET. ASHA defines this approach as an approach designed to improve word finding and increase the number of content words used by a person with aphasia. The clinician elaborates on the person with aphasia's utterances to improve conversational abilities. Therefore, the RET approach to treatment for persons with aphasia is a loose training procedure that uses the patient's topic initiations to increase his or her generalization of language use in the form of increased content and length of utterance. The approach was first developed by Kearns and colleagues and is best for patients with anomic or conduction aphasia. Anomic and conduction aphasias are fluent aphasias which occur when the damage occurs in the posterior portion of the language dominant hemisphere, often the left hemisphere. Anomic aphasia can be characterized by fluent speech and intact receptive language abilities, however, a deficit in naming abilities. Conduction aphasia is also characterized by fluent speech, however, the patient has difficulties in written expression, repetition of words, phrases, and sentences. This approach works by the clinician using pictures that lack context to prompt the patient to initiate a topic of his or her choice. This initiation is then used as the starting point for treatment. The clinician provides continuous reinforcement, modeling, and prompts to expand the original utterance to improve the patient's conversation abilities. The clinician takes the patient through a 6-step process in order to eliminate the training of a specific target response, which will be described on the next slide.
The 6 steps are as follows. The elicitation of the initial verbal response to the picture. The clinician reinforces, models, and shapes the initial response. A WHQ is then used to elicit an elaboration of the initial response. The clinician then reinforces, models, and shapes the 2 patient responses combined. The second model and request for repetition, and the 6th step, after reinforcement, elicit a delayed imitation of the combined response. In this example, the clinician presents the client with a picture of a man with a broom and asks the client to tell her what's happening in the picture. The client responds with, "Man sweeping." The clinician then provides feedback to the client by reinforcing and shaping his or her initial response. "Great, the man is sweeping." The clinician then elaborates on the initial response with a WHQ. "Why is he sweeping?" The clinician responds with, "Wife mad." Again, the clinician reinforces the client and shapes both of the patient's responses. Way to go! The man is sweeping the floor because his wife is mad. The clinician then prompts the client for a repetition. Try and say the whole thing after me. Say, the man is sweeping the floor because his wife is mad. The client responds with, man sweeping, wife mad. After reinforcing the client again, the clinician prompts the client for a repetition. Now try and say it one more time. The client finally responds with a more accurate response of, man sweeping because his wife mad. Watch our example of this. Tell me what's happening in this picture.
Pointing map.
Great, the woman is pointing to a map. Why is she pointing to a map?
She lost.
Way to go! The woman is pointing to a map because the other woman is lost. Try and say the whole thing after me. The woman is pointing to a map because the other woman is lost.
She pointing map. She lost.
Good job. Now try and say it one more time.
She pointing map. 'Cause she lost.
Good job.
The RET was first developed by Kearns and colleagues. He conducted a study to evaluate the effectiveness of the RET program. The participant was a 50-year-old man with moderately severe Broca's aphasia and a mild to severe apraxia. Training included 30 black and white drawings that represented transitive and intransitive verbs. The 30 line drawings were divided into 3 sets of 10 items. 2 sets were used as training items, while the third set was used for probing generalization. The experiment consisted of 2 phases, baseline A and treatment B. The 30 stimulus items were randomly presented during each of the baseline sessions. Any information conveyed that was clearly relevant to the stimulus picture was tallied. During the treatment sessions, training items were randomly presented in a 6-step sequence. Training continued for a specific set of items until the participant spontaneously produced 5 or more words in response to at least 8 of the 10 items. The clinician combined successive patient responses, modeled them for repetition by the patient, and then prompted the participant to provide more information as we have earlier described. The patient's utterances were used as building blocks for developing more elaborate responses. After treatment was concluded, the mean number of content words was consistently 5 or more for both sets of items. Essentially, the results provide support for the efficacy of response elaboration training, as well as moderate degree of generalization occurred for untrained familiar items. According to Davis, in 2000, RET was first introduced to a patient with Broca's aphasia, whose performance increased across the treatment period. According to Wambach, Wright, Nestler, and Mazwicki, during 2014, RET as a treatment method specific to aphasia that has been modified for use with persons with apraxia of speech. It has been shown to consistently result in increased production of content in discourse. Wambach and colleagues also found that the participants in their study generalized to untreated sets.
So these are a couple of the questions that we came up with. Our first question is, using the RET procedure chart, formulate your own example of a clinician and client interaction. And our second question is, how would we generate a patient-specific hierarchy in the HELPS model? I hope you guys learned some information about the HELPS and RET approaches, and thanks for watching.
And here are a couple of our references. Thanks.